Hi, welcome to Infusion Health, the podcast. I'm comedian Chris Patrick, a.k.a. self-proclaimed power man. And I'm here with my co-host and significant other, Rach.
Hey, guys.
Now, today, as you all know, Rachel is in the medical field. She's a CNA, and today we're going to talk about bias in the healthcare system. And we got Scott Faust, who's a nurse practitioner and educator, and we're going to learn all about some of the bias things that go on in the healthcare system. Scott, welcome to the show.
Thanks for having me.
So what exactly is bias in the healthcare system?
Well, bias occurs not only in the healthcare system, but everywhere we go. For the health, bias is our view, whether it's right, wrong, good, or bad. It's been around for years, from the beginning of time. But why now? Why is it causing us to have tension? And why are we paying more attention to it? Couple things. One, we are coming out of and climbing out of the aftermath of the COVID pandemic.
Mm-hmm.
Pandemic continues to unfold, but we're getting to a point of stability.
Mm-hmm.
And then other social and just personal challenges that people are going through. You know, we're still recovering from societal issues. The George Floyd incident here locally still has an impact. And what we're finding is that people, both patients and healthcare providers, are sick and tired of the status quo. And they're also sick and tired of being ignored. And what we see is that within bias in healthcare, there's also disparity. It's kind of the have and the have-nots.
Mm-hmm.
And what it really points down to is differences in health and the healthcare between groups that stem from deeper issues. One of those deeper issues is racism.
Mm-hmm.
Another issue is equality or distribution of resources. But I think in order to really understand what bias in healthcare is, we have to know what makes up healthcare or what.
Okay, well, so when we say bias in the healthcare, are you saying that if it's a choice between this person has insurance and this person doesn't have insurance, the person who has insurance is going to get treated first, or this person is black or this person?
Not necessarily.
Right.
We always look at who needs to be treated first. It's like the convict or the police officer, right?
Yeah.
But the quality of care could be treated differently. And it's not just like having no insurance. It could be having state insurance. It could be having a lower class kind of insurance.
Mm-hmm.
And it also has to do with insurance itself. You know, you got your plan A, plan B, and all that other stuff.
Mm-hmm. So those people get treated, or they don't get treated, or?
Well, it's not. It's more than just if they get treated or not get treated. A lot of it comes down to access to care, as well as the person or individuals feeling heard. And getting to be seen. Healthcare is such a diverse and dynamic topic.
Mm-hmm.
There are things that make up what we call the social determinants of healthcare, the social aspects, and that's the biological,
Mm-hmm.
genetic, who you are, behavioral, the social and cultural, believe it or not, nutrition and lifestyle, as well as environment and genetics, all make up aspects of our healthcare.
Mm-hmm.
The big one that you were alluding to, we can get much deeper into it, is the economic. But then we also look at ecological aspects.
Mm-hmm.
The problem with when we talk about bias in healthcare or access to care is that it's objective, but also very subjective.
Mm-hmm.
And as a healthcare community, we have a hard time even getting a unifying definition.
Mm-hmm. Well, what happened? What happened in the healthcare industry? Because I remember when, years ago, doctors made house calls, and the doctor wasn't the richest guy in the neighborhood. He got into it because he liked doing it. He liked helping people. Everybody knew him and all that. But now it's gotten into this big, like you said, economic diversity.
Well, you're talking about just one type of bias also.
Okay.
There's the color barrier, right? You're talking about your blacks and your Mexicans. Mexicans are usually thought of at, they can live in America their whole life. Their grandparents could have lived in America their whole life. And you're looking at, is that person illegal? You know, and history has been shown as blacks having a bias in the healthcare industry. One thing I can think of for sure is how OBGYN was started. Black women were thought of as having a higher pain tolerance, so they did not use anesthesia, and they were performing these new thoughts of how to work with the reproductive system. So these black women had no pain, narcotics or anything like that. And they're put through these rigorous things.
Well, I remember years ago driving back from Florida with my mom, helping my mom drive back from Florida because she was working in Florida. And we stopped in Lawrenceburg, Kentucky, where she was born. And we're in my uncle's house, my great uncle's house. And my mom goes, I was born right here. And I said, what? Why weren't you getting? She goes, because back in that time, we couldn't go to hospitals. I'm like, what? She's like, yeah. And so is that kind of like bias in the?
It very much can be. If you think about it, think about the differences between the groups, like we were talking earlier about who have healthcare funding, those who have private insurance versus state insurance versus no insurance. Bias, and it's more than just bias, it's also disparity. Bias certainly impacts the disparity, but if we were to peel back the proverbial layers of an onion, we have the bias in healthcare, but it stems from something. Research points to racism, but there's even more than just racism. A lot of it is disparity.
What about classism?
Class rank, or rank and file. The traditional, even in medieval times, of the different hierarchy and classes of people.
You were talking to me about just elderly yesterday.
Yeah, it's really interesting that the disparity and bias in healthcare is not just, while it is predominantly race-driven, but if you think of anyone who may be marginal or sitting on the outside of what we consider mainstream society, when we look at, and the thing about disparity or healthcare disparity is these are preventable differences in the burdens of disease, injury, or violence. Regardless of what your ethnic background is, regardless of what your color is, we all bleed the same. We're all human. We're all part of this race. But there is this difference, and disparity and bias occurs on a continuum from birth to death, rich and poor. But oftentimes it's seen through the lens of race and ethnicity. But think of any time there's a barrier or limited access to care, or even the quality of care. You brought a really good point up about your great uncle. Research has shown that in many parts of the United States, your zip code is more of a determinant of one's health than their own genetic code. One's education. You also, we talked about before the show started, and we've alluded to in the past of, how is healthcare delivered? Over the past 20 years, we've had a radical shift from what I would call the paternalistic approach, where you went to the doctor, you gave your symptoms to the doctor, a physical exam was conducted, and they gave you a prescription, and you went out and either did the prescription or did not do the prescription or the course of treatment. You either got better or you didn't get better. But you really had a limited role in the past 20, 25 years because of just the evolution and need of humankind. We've become much more team-based, and the patient, the individual, having a seat at the table And so it's much more participatory healthcare. So no longer do you go to your provider, whether it's a nurse practitioner, a physician assistant, a physician, a surgeon, whoever it may be, therapist, you act and tell them what's going on, and then they give you a course of treatment. You actually now go, and the expectation is that you are an active member of your healthcare team. The problem is there are a lot of barriers that get put up.
Mm-hmm.
And I would think when they're bringing somebody to the health, changing that the physician knows everything, right? Into let's bring the team in there and include the patient. Google search is not helpful. But because the patient's afraid still to this day to ask the following questions, their lack of knowledge is not getting them to the ultimate care.
Absolutely. So it's also not just healthcare. There are many factors that impact the bias, as well as the disparity of healthcare. One such thing is economic stability, thinking of employment opportunities, income, expenses, debt. I mean, how many of us know individuals who have to make the hard choice if they put food on the table or if they take their medications?
Mm-hmm.
Yeah.
And they may very well even have good, or we consider good insurance, but at the same time, medications are costly. Think about education, the vast differences of education. Anytime you go into that setting, there's a power play.
Mm-hmm.
And if the listeners get one takeaway point from this, and one point from this only, is to encourage them to advocate for themselves and their loved ones. But anytime you go into a setting such as healthcare, there is a team dynamic, there is a power play, there is this power differential, and that creates barriers. That also creates biases.
Well, like you said about should I get food or should I get my medication? I think, and I'm gonna say it, I think it's a damn shame that you have to go in front of Congress. Now you have to go in front of Congress to ask Congress, can people get their insulin? And the people who invented insulin, who came up with insulin, they sold it for $1 because they said people need this.
Right.
So why would you have to go in front of Congress to get people to get their insulin, and people had to ration their insulin? I think that is just that should be a no-brainer.
Well, for me,
and that's on both sides of the spectrum, Republicans or Democrats or whatever. But why do we have to do this for insulin?
absolutely, I 1000% agree. I just lost a cousin because of I'm strongly thinking that it was because of insulin. The mother didn't tell us why she passed away, but she was selling her insulin so she could pay rent. That's really what other sources are out there to help that person before they become so desperate to leave go of something that's life-saving.
Absolutely. And the short answer is the system is broken. And when I say the system, our political, our healthcare system, everything is disenfranchised. It's no longer working, and it hasn't worked for some time. And I think, unfortunately, it took a pandemic and social issues for people to say, I'm tired of the status quo. I'm tired of not getting healthcare.
Mm-hmm.
I'm tired of not getting resources. And keep in mind that healthcare is more than just medical healthcare. Healthcare includes dental healthcare. It includes mental health care. It includes the physical health care. Also food. Believe it or not, food is medicine.
Yeah.
Yeah.
Without good, with you being a chef, this probably more than I do. That nutrition is at the center of what we do.
Yeah. Well, I'm not a chef. I just
Oh, I thought you were a chef. So.
Well, you're heading into the business of baking.
baking. Yeah.
Yeah.
I'm not a chef.
But just talking about what we witness just on the floor alone. We're witnessing how do you get past these biases? And it's easily with a conversation, but it's also observing.
Absolutely.
Well, I'm going to step back just a couple steps. Like you said about the pandemic, what the pandemic taught us. And one of the things I found what the pandemic taught us is that a lot of people were going to work, because we had this, I got to get to work. I got to get to work. Okay. And I've always been a big advocate of listening to your body. If if you're sneezing and your temperature's high and all that, stay home, and people are like, I got to go to work. I got to work. So now what I found since the pandemic is like, hey, I got a real high temperature, and your boss like, stay home, because why come and infect anybody else? We don't know what you have yet and all that, and it's kind of opened an eye for that. So I'm not saying it was a good thing, but it kind of was an eye opener with the pandemic, And I say to listeners out there too is that if you do feel sick, you do got a high temperature, don't try to tough it out and going to work. Just stay home, listen to your body.
Oh,
But
absolutely.
there is a bias also with that employers are wanting to get back to that. Like, you're sick. Okay, well, how sick are you?
Yeah, and we
How
shouldn't do-
contagious are you? That's what they're kind of looking at now. Not necessarily a temp, not necessarily throwing up, but how that level of contagion.
Mm-hmm.
Contagious. Sorry. Yes.
But Scott, what can we do as people, as citizens, as patients? What can we do as far as trying to fix the system, trying to find how do we every politician who's running for anything says, I'm going to do this for healthcare, and then they don't do nothing. How do we start to hold these people accountable?
Well, I think before you even hold them accountable, we need to look at first who this impacts.
Yeah.
Because it impacts, believe it or not, because you and I were talking at the hospital one day, what ethnic group sees this the most?
Mm-hmm.
Individuals and people of color.
Yeah.
People of lower economic populations. You brought up the thought of the elderly. I call it the honey phenomenon. How many times as humans, including myself, have we been guilty of calling an elderly person sweetie or honey as a term of endearment?
Mm-hmm.
But that creates a bias. Believe it or not, children and adolescents are also impacted by bias and disparity of healthcare. And we also see the individuals who live in rural and inner cities. It's just not those who are in the inner city hospital or in the inner city of a big town, but also those who live out in rural America,
Mm-hmm.
where oftentimes access to care may be hours or a couple hours away.
One more that I can think of is physical or mental health problems, like talking about that person in the wheelchair, or talking about that person with bipolar. I've definitely heard it on the unit, and I've corrected it. I myself suffer from bipolar, but it's not as much as suffering if you know what to do, right? I can be held accountable for my stuff, but there's sometimes people on the unit that say, oh, they have bipolar, they're just going to act like that. Well, no, they don't just have to act like that, but you need to take account that they do have that. So what are you doing to help them through that moment instead of passing narcotics or, allowing them just to sit in the bed and eat all the junk food that they've brought in extra,
Wait, they bring junk food in?
Yeah.
What, potato chips?
Yes.
Because we don't control. We recommend a diet. But we're not enforcing it. We're not requiring them oftentimes. And so oftentimes we know that food, is comfort.
Mm-hmm.
Yeah.
That's why people typically during periods of stress will sit around a kitchen table.
Mm-hmm.
The concept of breaking bread and sharing bread as both biblical history as well as cultural and historical and contemporary impact. And so they'll bring in, think also about like historically taking women's pain less seriously.
Yeah.
I mean, even currently we talk about, women don't have heart attacks the same way men do.
Right.
That automatically creates a bias. It creates a us versus them.
Perfect case in point. My grandma, when she was pregnant with my aunt, was told, "No, you are not having the baby. Stand up and get on the gurney." The baby fell out. Pat was forever handicapped after that.
Absolutely. I mean, and while we have made tremendous progress, there is still a lot of progress to be made. Think about, we think body habitus, we think body size. It's just not the morbidly obese who get, bias or victims of bias. It's also the super skinny. You look at someone and they're, very skinny, you go, oh, they must be anorexic.
Right.
Or they must be bulimic, or they must have an eating disorder. Or you look at someone who has an obesity issue, oh, they lack willpower.
They eat too much. And it could be what's going on in time. They could be eating completely healthy. They could be going to the gym every day. There's something going wrong with their body, not them, that is adding to this obesity.
Yeah, slower metabolism.
You also talked about kind of, mental health issues. There's actually, unfortunately, an overdiagnosis of schizophrenia among racial minority groups. Disregarding the gender minority of the LGBTQ population.
Yes.
Or even we were talking about, loved ones who've been impacted by both historical and recent biases of healthcare. We're less inclined to treat individuals with disabilities. We're getting better. We've gotten better over the years, but we still have a long way to go. And before we really get to the meat of the matter of how do you get through this, how do you advocate? Also, anytime I look at a problem of interest, I always have my own so what test. And so what? Why does it matter? Well, there's broader implications, not only healthcare, but improving, if when we get to talking about taking care and solving and being an active participant to minimize the bias and the disparity of healthcare, looking at, improving the nation's overall health and economic prosperity. We know that people of color and other underserved groups experience higher rates of illness and death across a wide range of conditions, which limits them in their overall health of the nation. Most importantly, if nothing else, if you were to talk about the financial aspect, we all pay. Disparities amount to approximately $93 billion annually in excess of medical care costs and $42 billion in lost productivity due to illnesses and premature deaths. But most important or most interesting for me, and another call to action of why, is because people of color are projected to make up over half of the U.S. population by 2050. So in less than 30 years, it is projected. And that's a pretty good, solid projection.
Well, like I said before, what do we do as far as getting our politicians, talking to our politicians?
Well, talking to your politicians is certainly a key aspect, I think, but there's some grassroots levels issues and things you can do. If you come from the perspective that what do we do or how do we even get there? I think an author, Rick Riordan, once said it best when he wrote that fairness does not mean everyone gets the same. Fairness means everyone gets what they need.
Right.
And as healthcare providers, we have to look at, do we treat all the patients the same, meaning equally, or do we treat patients according to their unique needs, which is not equally, but equitably.
Right.
And so I think the first thing we do, and I would be happy to share the links, it's important that we all, whether you are the healthcare provider, you're the loved one, you are just Joe Smith on the street, whatever we are, whoever you may be, that you recognize your own explicit and implicit biases.
Yeah.
Mm-hmm.
There's a couple of ways you can do it that are evidence-based. There are a couple online tests you can take from a smartphone, from a tablet, or from a computer.
And you told me you were going to give those to me so I can put them in the show notes.
Absolutely. So I think recognizing your own explicit and implicit biases, I think you break it down further. You know yourself, you know your needs, and you know, most importantly, how to get what you need. So once you know or identify some of your biases, you can become aware and adjust your responses. The next thing you do is you advocate for yourself and for your others. Do your research. Identify healthcare providers, and this can be a challenge, but it's worth doing, that you feel comfortable with. You have the right as a healthcare consumer to have access to care, but also to be listened to and felt validated. And sometimes it may require you trying a different provider. We also know that time is money. Regardless of what you do for a living, your time is just as valuable as the healthcare providers.
Right.
So one of the things you can do is list out your questions ahead of time. Because how many times have you gone somewhere and it's fresh on your mind, someone distracts you, or you get nervous and you can no longer think of what was on your mind? Be specific and include details. You are the expert about you. We are the expert of the healthcare system. And I will often tell my patients is one way to see my role is that I am a tour guide on a trip that you may necessarily not wanted to go on. And so it's my job to point things out. But it's your job to tell me if it matters. Because as the old saying goes, mind over matter. If it doesn't, if you don't mind, it doesn't matter. But if you mind, it matters a whole heck of a lot. Explain your concerns. You don't have to have a medical education to explain your concerns. If something hurts, when does it hurt? How does it hurt? What do you describe it? Use terms and words that you feel comfortable with. As a healthcare provider, we will work with you to clarify. And so if we're asking questions, keep in mind that hopefully the goal of our asking questions is seeking to understand. I also tell people to build in time for your appointment. So if you have an appointment at 1:15, be there at 1:00.
Right.
You may sometimes get seen early. You may not. You may get seen late.
You might be seen at 1:45. Have your patience. Be patient.
But if you're there, then you can take some deep breaths. You can just prepare yourself because it's nerve-wracking.
Yeah.
I mean, although I'm a healthcare provider, I'm also a consumer. And I know what it feels like to be a patient.
Right.
And you're sitting there. So you can kind of, process of why you're there. I also say recognize that you may disagree with your healthcare team, and that is completely okay. We actually want that if that's going on. As a healthcare provider, as a nurse practitioner, none of my colleagues can know what every insurance program covers.
Right.
There are many, many drugs. There's many different treatment options, and we kind of get comfortable with our routine.
But I think you also need to be open to other things other than just drugs.
Absolutely.
There's essential oils, there's heat, there's cold, there's so many others. Yes.
Exercise is big. As I said before, food is medicine. Food is treatment. And you really want to build a good rapport. So not saying that everyone does this. I personally have been guilty. You get busy and you forget you have an appointment. You make sure that doesn't happen often. If you have an appointment and you can't keep it, as much notice as you can give to the team to reschedule may allow somebody else to take your spot.
Sure.
They also know after a while that if you don't show up, something's got to be wrong because, the past 10 visits, you've been here early and you're not here. What's going on?
Mm-hmm.
It may be human error and we just forgot. Or it may be that you're home sick, but you're often going to get a follow-up call just to check on you.
Sure.
I also think it's, and this sounds kind of counterculture, know when it's time to look for a new provider. Not everyone's going to be a good match. If you feel that you're not being listened to, if you feel that you're being rushed, you feel that you can't ask questions, or that you don't have time to address the questions or concerns, speak up. And if you're still not getting anywhere, it may very well be time to change providers. The other thing to do is ask questions. I will often tell my patients that it's your job to ask questions. It's me and my team's job to explain things in a way that you understand it. And if that means you have to ask a question 100 times, I will gladly explain it 101. If you're not getting it, it's not you. There's something going on that's causing a breakdown, but it's not you. And the ownership is on our team to help you understand it. I also recommend, and I can't stress this enough, bring an advocate, bring somebody. It could be a relative, it could be a friend, it could be a spouse, it could be a caregiver. There are also at times kind of industry secrets or trades of how do you maneuver the system. I tell people, be mindful of what time your appointment is scheduled for, and what you're most likely to be engaged. If you're not a morning person, a 7 a.m. appointment's probably not the best for you.
Right.
If you have to be at work at 7:30, a 7 o'clock appointment's not going to work. If you know that you need more time, when you call to schedule, ask. Say, instead of a 20-minute slot, can I have a 40-minute slot?
Right.
Now, that may mean that you have to work your schedule and your calendar so that you come late morning before lunch or at the end of the day. Be willing to be flexible the best you can. At the end of the day, be an expert in you. When we talk about treatments, it is okay, and I encourage this. Ask, is this something you can afford? More importantly, ask, is it even necessary?
Right.
Are there other options? And there are other avenues out there. There are, for those who have a hard time, and we can kind of talk about this as well, either now or down the road, but there are pharmaceutical and manufacturer assistant programs.
Yeah.
How many times have we seen on TV pharmacy programs like GoodRx? There's another program called RX Assist or Needy Meds. Ask, your provider. While many of us don't carry samples in the clinic anymore, some of us still do, or we have access to samples. So ask for that. Work with your pharmacy. I encourage people to have one pharmacy. That they go to.
I think that's so well said, that you should have one pharmacy, one pharmacist, at least, because my mom is like on 42 medications.
Dang.
And she was getting them from different places, different doctors, different this, different that. They started saying, bring in all your medications. We are going to set up your medications, because she thought her dementia was coming from Alzheimer's or something like that. And she was actually having medication-induced dementia from the side effects from the medication. So I think it's important to say one pharmacy.
Absolutely. One pharmacy. And ask the pharmacist, and it's going to take some time. So this is, we all have to be patient with each other. And believe me, I know it's easier said than done.
Yeah.
We have to be patient with each other, but advocate for yourself. Ask your provider, do you think this will impact with any of my other medications? We can do a relatively quick glance, there are apps and there are different programs we can use. There's a phone call to the pharmacist. The pharmacist has more resources at his or her disposal. Mm-hmm. They can look for medication indication. One of the things we've seen in the healthcare industry, especially in the acute care setting, that one of the most likely times of a medication error is at time of admission and at time of discharge when we're reconciling these medications. Mm-hmm. And so looking to see, are there any potential medication, interactions like your mom?
Yeah.
One of the first questions should always be, well, is this not just dementia? Could it be something else?
Right.
And are medications playing a role? Mm-hmm. I also advocate people to get copies of their medical records. I think the idea, at least in theory, of a universal healthcare system has its strengths and its weaknesses, its right. pros and cons. But I think one of the goals I hope to see in my professional, if not my personal life, is that we get to have a universal medical record. Mm-hmm. What people don't understand is that when you have multiple, healthcare systems in town, yes, we may all have one similar medical record, mm-hmm. but it's not the same medical record. And oftentimes we have to do a backdoor approach. And so we don't get everything that we may need, mm-hmm. or some of it gets lost literally in translation. And so I always advocate people to get copies of their medical records. And getting copies of your medical records can be its own potential nightmare. Mm-hmm. But if you are offered the opportunity to have electronic access,
right.
Things such as My Chart or Remote Chart or different login options, mm-hmm. that's a great way to go. Physical copies of records are certainly welcome as well. Know that healthcare provider education is ongoing. We're working to eliminate. I don't know if we'll ever be able to eliminate bias,
right?
Because
mm-hmm.
we're human,
right?
But to contain it, to modify it,
mm-hmm.
And I think to your point, Chris, when we were talking about what do we do at a legislative issue,
yeah,
we work with both our state and our federal legislators to decrease and minimize the biases and the healthcare disparities. Although it's outside the germane of this particular podcast,
mm-hmm.
I'm sure I could start World War III by saying Republicans and Democrats. It's beside that point. Whether wherever they may feel about our current both legislative and presidential landscape, mm-hmm. do you know that the Biden administration has identified racial equality as well as healthcare equality as key priorities? And so I think over the next several years, mm-hmm. we will continue to see this. We saw this even out of the Obama administration, mm-hmm. with the Affordable Care Act,
right?
Helping to increase access to healthcare.
Mm-hmm.
And so I think it's helping each other.
Right.
Mm-hmm.
It's being willing to put yourself in a position of vulnerability. Mm-hmm. Mm-hmm. That comes at a cost. You risk the risk of not being heard or listened to.
Right.
But then you don't take no for an answer. You go to
mm-hmm.
the next provider. You go to the next source. And if you find
I think that's important also.
Yeah.
Sorry to interrupt. Right. Instead of getting louder, finding out what the next step is. Instead of getting louder, because unfortunately, even in bias, no matter what race you are, no matter who you are, when you start getting louder, people find that offensive. And it is a huge bias that we will never, ever, ever get over. Mm-hmm. But it's more of what's the next step. Mm-hmm. And if something hurts, I had a pastor that was having a catheter put in. And he's like, ow, ow, ow. Well, of course that hurts, right? But there was something blocking it. He finally was moving away from them saying, you need to stop right now. Just check it out. So there's always a time where you can blow your tool, you blow your cool. But always think of the next step instead of I'm going to instantly react and get my reaction from them, because it might not be the reaction that you need in that moment.
Absolutely. And I think it also goes along the old saying of you can attract more flies with honey than you can with vinegar. If you are much more receptive, it's okay to say, I don't know, but something is wrong. I cannot tell you how many times by just stopping and listening to the person, we've been able to confirm that, yes, something is wrong. It goes back to what I said earlier, that you know you the best. If you say something is not right, it's certainly worth a deeper look. And being willing to advocate for yourself and say no. So your pastor did the right thing by saying, stop.
Yeah.
Yeah.
You know, what you can expect in the healthcare system is you can expect things to be explained to you in a way that you understand it, in a language that you understand it,
Right.
or in a method that you understand it. You have the right and the obligation to ask questions. You have the right and responsibility to say, I don't know, or I am concerned, and to voice your concerns. But I think at the end of the day, it's going to take all of us working together to help minimize. I think if nothing else, you realize that we're human. It doesn't provide an excuse, but an explanation. If you think that you are on the receiving end of disenfranchised healthcare, or if you think that there are disparities, there probably are disparities, and it's okay, and it's your right to speak up. You know, I think it's important for us to realize that the disparities in health and healthcare affect primarily all of us, but we're seeing it predominantly in people of color and underserved groups. These are the ones who have the long-standing challenges. You know, social and pandemic issues have caused an intensive focus in us addressing these issues. And it's not only important from a social justice perspective, but also from an economic perspective.
Well, Scott, this has definitely been an interesting conversation, and there's a lot to do out there. And to the listeners out there, make sure you're doing your own research. And Scott, if somebody wants to get a hold of you, got a website or something?
I do. I'll get it in the show notes.
Absolutely.
Rachel will have it in the show notes. Well, like I said, this has been an interesting conversation, and there's diversity out there. And check with your politicians and make sure, you know, they're doing, because remember, they work for us, and remember, they're doing what we need them to do, and also too, like Scott said, do your research and checking kind of what kind of medical treatment works right for you. And if you have to, you may have to change, you know, your doctor. And I'll let Rach close us out.
All right, you guys, we come to an end. Always step up and be your best advocate. And until next time, go look over at the show notes and see where your bias lies. Have a great one.
Take it easy.